particularly when the large element, mental hospital spending is excluded. Now, in the corporate hospital, I want to tell you one very big truth that we don't have coverage or inclusion criteria for the inpatients of mental disorders. Okay, so you cannot hospitalize the mentally ill individual or person who is having mental disorder like depression or schizophrenia or bipolar or substance use disorder in a normal corporate hospital or any other nursing home. It is not included. And forget about billing, forget about getting assistance from the insurance or government is out of the sight. There is a strong international consensus that the shortage of financial and human resources for mental health requires a policy to integrate mental health care into general health care. Such integration provides opportunities for reducing the stigma of mental health problems, which in itself is a major barrier to accessing care. Okay, now what can we do? We have learned so many things. What can we do? We have to scale up the services. We should become more and more aware that we are available in the present medical market. That means the psychologist should be more visible, that we are open to help you. Whatever problems that you have, we are here to help you, and we can fix your problems through our approaches. So the more visibility is needed. So more visibility comes with the more awareness that you create among the general public. So you have to scale up services. Means you should be visible not only in a school, college, or a NGO, or on the social sites, that you do one program and keep on running the same clipping every time. That same photographs often appears, just like Deccan Chronicle one in the page 4. One photograph comes after 6 months, again that fellow will repeat the same photograph. This is the plight of the present psychologist. No, you should be seen. You should be the psychologist services. I mean to say psychologist at large. I'm talking about all over India, not only Hyderabad. The psychologist should be visible not only in a particular domain, not only in a particular stream, not only in a particular organization, not only particular taking up only one particular service, including Shava Panchanama also a psychologist can do. Okay, psychologist should be seen. He should be catering his services. Okay, so you have to think, you have to rationally think, you have to explore what are the utmost possibilities. Okay, there's so many other areas where psychologists have not thought of or seeped into. We'll come to that later. Now, task sharing with the non-specialists. Now the problem here is our psychologists have got so much a huge ego. The problem with the ego is somewhat that they are not able to go forward. Okay, so the clinical psychologists, they do not like the counseling psychologists. They feel that they are superior people. They are the big guns in the field. And the psychiatrists think that they don't need clinical psychologists. And the social worker thinks that we did not have to work with any counseling psychology. We are our own specialist. And the psychiatric nurses, who are also part of the mental health team, they think that we don't need to work in conjunction with the counselors or psychologists. Okay, and there are educational psychologists, counseling psychologists, there are experimental psychologists, psychology teachers, they are counselors, they are mental health counselors, rehab psychologists, criminal psychologists, so many psychologists. But who are keeping busy? How visible you are? How much you are rendering your services, and how much your services are extended to the common man who is in need is a big question mark now. Okay, now I've been in this field for the last 20 years as a specialist, and now let me tell you frankly, I have worked in the best of the best, topmost institution called Krishna Institute of Medical Sciences, KIMS hospitals, for almost 10 years as a head of the department and assistant professor. Of course, I am now also a visiting professor to some of the universities who teach clinical psychology, who have a master's program and the integrated program of clinical psychology. Do go there and teach therapies and counseling skills to the trainees. Of course, I teach MPhil clinical psychology students on specific topics like EMDR and hypnotherapy, SRPT, and some specialized areas. Okay, but the thing is that 10 years before, when you take 10 years before, nobody in a corporate hospital do not understand who is a psychologist, what cases should be referred. They don't have any idea. They do not know that a clinical psychologist do exist. So this is the thing in the medical community. Many of your clients do not know the difference between a clinical psychologist, a general psychologist, and a psychiatrist. Okay, so we try to blow our trumpet our own that we are doing this, we are doing that, we are doing that. No, we have not reached the common public yet. I have been doing more than 1,500 shows on television and giving education programs on clinical psychology, mental health for the last so many years. But still, it is just a small grain in the sand. That's what I feel. So we need to contribute at large. How can we do that? By sharing our task with the non-specialists. So what we call in technically speaking, we need to create, all psychologists cannot reach the villagers, the background areas. Okay, all clinical psychologists cannot reach the general public. We are about 1,500 clinical psychologists who are licensed in India, who are specialists to diagnose, treat mental disorders. But all these 1,500 people cannot reach the 100 or 150 crore Indian population. That's impossible. So we need to take the non-specialists, like you can take the help of the counseling psychologists, you can take the help of the general counselors with BA psychology, post-graduation diploma program people, you can reach the psychiatric nurses, you can take the help of the rehab professionals, you can take the help of the what we call speech therapist, we can take the help of the medical social workers, psychiatric social workers, so who are non-specialist in mental health. I mean to say, especially for the diagnosis purpose. You can work with them. Okay, so there is no ego issues that you should not work with a non-specialist. Okay, just like in a hospital, there'll be a consultant. Under the consultant, there'll be residents. These residents are not actually the consultant, means a medical specialist, but they are MBBS doctors who are working under the supervision of the consultant, that is a specialist. The same way, the medical doctor who is an MBBS has his own knowledge, has his own skill, has his own approachability, has his own method of treating the things. But he needs some kind of supervision. He needs some guidance. With this, he can reach a lot number of people and help people very judiciously, wisely. Okay, we need to extend our services with the help of the medical doctors, like that in the medical field. So the consultant is out of I mean to say, out of station with some conference or something. When a case comes, he admits the case under the consultant name, and the medical doctor, our MBBS doctor, will treat. In a similar way, here, though the clinical psychologist is not available, the general psychologist or a counselor or a social worker or whatever coach, whatever you call, relationship coach, whatever you are, if you are trained, if you have a certification in psychology, and the legislation says that you can practice counseling with the virtue of your degree, either BA or MA or MSc psychology or MPhil counseling psychology or whatever degree that you have, okay, you can work with the specialist, or the specialist can work with you. We can take your help. You can help. You have your own recognition. You have your own worth. You have your own skill. You are not less than a clinical psychologist. You are not less to a psychiatrist. You are not less to any other person. You have your own thing, but you need to work in conjunction. That culture should come in India. So the clinical psychologists can share work under the supervision. They can help the counselors or psychologists to work, to learn, to have more skills, so that they can help the common public who are in specific needs. People come to you not because of your degree. People will not come to you because you are a renowned person in the field. People come to you because they want genuine help from you. They understand from whatever they read or hear from you, you are going to help them. And with that faith, they come to you. If you are not able to help them genuinely, no matter whether you have a big name, you have a big degree, your PhD or doctorate, or you are MSc psychology, whatever certificate that you hold and whatever recognition that you have, it is useless in the eyes of the common man or a client. Okay, so here we need to learn how to share the task. We'll come to that later. How can we do the sharing of the task? Okay, so if you are a counseling psychologist, you can take a case. You can take a case. You can take all the information gathering. Do not attempt to do any clinical cases like anxiety disorders or phobias and all that, because that's a clinical stuff that is beyond your understanding. So that needs a lot of knowledge on psychopathology, and you need hands-on experience to do psychotherapy. So you can refer that case to a clinical psychologist. If a client comes with some severe problem where there is emergency, like he is hallucinating, he is hearing voices, or he has preoccupations about alcohol, he does not have control over his anger, then immediately you need to refer that case to a psychiatrist. Okay, and same way, if there is some case that you can take, you can take the data. You understand that this is my case, it's not case. If it is not your case, you can take the help of the clinical psychologist, or the clinical psychologist himself is so busy with the assessment and therapies, he can send cases to you for compliance counseling. Okay, to give compliance to the medicines or to give compliance to the therapies. He can also give you cases for family counseling, or for psychoeducation program, or for stress counseling, or for couple counseling, or for relationship counseling. These are subclinical areas which a counseling psychologist can work in conjunction with the psychiatrist or work independently. So this is what we call the sharing the task with the non-specialist. What causes mental disorders? Mental illness results from complex interaction between the mind, body, and environment. So there is always biopsychosocial model. The psychologists only look at the psychological model. Sometimes they look at the social model, but we also have to take into consideration biology. There is psychology and there is sociology. That means the three different factors are there. Biological factors like elements in your body like sodium, potassium, calcium, magnesium. This will affect your functioning. And so now coming to our role as psychologists is to more focus on the psychosocial factors, and the psychiatrists will focus on the biological factors alone. So we need to integrate all the three, because the mental disorders come from all these three models. So mental disorders are of different types and the degrees of severity. So one is major mental disorder that most of the Indians do have is the depression. Worldwide, if you take also, you find the depression as a major mental disorder. Okay, so many people use this loosely. They have a loose connotations about depression, that I am depressed. If you don't get a seat, you get depressed, or things did not go the way you wanted to, feel that you are depressed. That depression is totally different from the clinical depression. Clinical depression, it has got a lot of symptoms. Okay, like there is concentration deficit, there is a retardation in the psychomotor activity, there is changes in the mood and affect, there is anhedonia, means loss of interest in the pleasurable activities. Okay, there's low energy, there are suicidal thoughts, and there's a depressive cognition, or what we call helplessness, hopelessness, and worthlessness. These are the depressive cognitions a person will have who is succumb to depression. You have bipolar disorder, that means you have mood elevation, mood depression, and you have anxiety disorder starting from OCD to phobias, agoraphobia and other phobia. So anxiety spectrum disorder, schizophrenia. Schizophrenia is a complex clinical syndrome. Okay, you will have all the bits and pieces. It is like a thali, which you will have anxiety, you will have stress, you will have OCD, you will have depression, you have features of personality, you will have a dissociation. You have all the things, including some organic changes also, like confabulation and all that. So it's a complex clinical condition. Okay, drug and alcohol disorders. So overview of psychological and medical treatments. So psychological treatments, that is the role of the clinical psychologist to do psychotherapy. Even a counseling psychologist can also do psychotherapy. psychotherapy, provided he or she has taken at least 6 months of training under a clinical psychologist, which is a supervised training. Okay, just by doing a 2 days course or a 1-day program on cognitive behavior therapy, you will not become a cognitive behavior therapist, because you have understood what is cognitive behavior therapy, but you are not trained to handle severe psychopathologies. So CBT minimum protocol is 21 sessions. It is not a Haldiram product that everyone will buy some namkeen from a Haldiram store and they eat. No, this is not that. CBT is a very, very Herculean task. It is not just easy to do CBT. You have to do minimum 21 sessions as per the protocol advocated by Ron Beck himself, who is the father of cognitive behavioral therapy. Okay, and it is a recent evidence-based approach, and you have gestalt therapy, you have clinical hypnotherapy, you have behavior therapy, you have psychoanalytical method, you have EMDR, you have so many other brief forms of therapy like SFBT and whatnot. So I will not give more focus on to this, because you've been already doing counseling and psychotherapies, most of you, and working together. How can we associate it? To engage the patient in the treatment process from the initial stage. So how do you start the treatment? By the initial interview, that is case taking. You will have the socio-demographic details, you have the chief complaints or consents, then the duration, then the diagnostic criteria for that, whether you have a predisposing precipitating factor, or you have protecting factors, or any maintenance factor are there which is delaying the disease, the improvement of the disease. Okay, so whether the treatment should be given in a hospital setup, or it should be first treated by the psychiatrist, or it should be treated by a clinical psychologist. And suicide assessment is very, very important. People who come to you with a severe suicide, this thing, if you do, there is directive approach and non-directive approach. People who come with suicide complaints, complaints with severe depression, mood, and suicidal ideas. If you do a non-directive approach, then the client will ask you, sir, I'm feeling suicidal, I don't want to live, I feel that life is not worth living. What should I do? Then the therapist will say, do whatever you feel like doing, whichever you feel comfortable at the moment. Then what will happen? You will attempt the suicide. So you are responsible, solely responsible, if a client attempts a suicide. In that case, it is the emergency psychiatry service. You have to refer that case. You have to assess on a scale of 0 to 10 how strong the suicidal thoughts are. Either it is a suicidal thought, suicidal ideation, or suicidal tendency. Okay, so what is the risk involved? Okay, in the same way, the risk involved with the severe psychotic conditions like schizophrenia, acute transient psychosis, okay, or alcohol withdrawal syndrome. Okay, you have to assess what is the risk now. Okay, or epilepsy. Okay, so you have to assess the risk and refer it to the immediate professional. Sometimes if the patient will not come with any attender, he will come by himself or herself. Then you have to take the number from the client or patient, and you have to call the attenders that this person has come, your brother or sister, mother or brother or husband has come here for this psychological assistance. So they have this problem. Would you please come here and take away your person, okay, safely? Or you can refer the case to the psychiatrist once the attender comes to you. Okay, that's how you have to do. And this is what we call the psychoeducation. Means you have to tell the informant that the client has some significant problem in emotion, behavior, thought, or there is a disturbance in his personality, or there is a decline in the functioning. Okay, he is not sleeping properly, he is not eating properly, he is not taking bath at all. Okay, he has grown up nails and it is neglected, and his speech, thought, everything is disoriented. So he needs some immediate help from a medical doctor, that is a psychiatrist. Okay, so after taking medicines, after a few months of time, he will come back to a normalcy. Okay, so he is not like you and me. So he needs some immediate help. With taking medicines will not create any kind of side effects. Okay, you have to discuss all these things. That session, we call it as a psycho education. Before you give psychoeducation, you have to do the assessment. What are the signs and symptoms of the illness? Okay, symptoms are nothing but the complaints reported by the client. Okay, so the technical word is symptom, but in layman jargon, whatever he says, I am not getting sleep, or my appetite is have gone down. Okay, I'm getting anger, I am feeling irritable, or I'm feeling helpless. I don't want to live at all. These are all the verbatims or the general words used by the client. We call this as chief complaints. In technical word, we call symptoms. Okay. So, is there any risk of self-harm? Some people, they slash their hands. Sometimes they, what you call, beat themselves or try to be very, what you call, aggressive, or sometimes very violent. Aggression and violent, there is a lot of difference. Okay. Violent means you try to harm the other person. You don't have any sense at all. So that is what we call violent behavior. So disabling, no, how disabling his illness is. Suppose he has severe depression, he don't feel like coming out of the house, he does not mingle, he does not have any social interaction, he does not eat well, he does not sleep well, always lost in thoughts, preoccupied with the thoughts of suicide, or sometimes he has psychosis, away from the reality, not able to understand what is real, what is real and what is not real. So these are things. So general level of coping, whether despite disease he is able to handle himself, despite problem is able to handle himself, despite the psychological problem, is he going to job, is he driving, is he eating his food, he is attending his chores at home. These are all things we need to. Was there any evidence of previous or ongoing mental illness? Okay. Is there any family history? Suppose we call it as a phenotype and genotype. Okay. The genotypes, especially, it is what is running in the family history. If the grandfather has an alcoholic, what do you call, ADS, that is alcohol dependent syndrome, there is a chances that in the down lane somebody can succumb to. Even in the case of seizure disorder, or it could be a schizophrenia, it could be a endogenous depression or anxiety spectrum disorder, whatever it is, you need to take the detailed family history. So what are the triggers? Triggers are basically the precipitating factor. Okay, with the fever, you have a trigger. The disease comes come to an onset, or there could be some triggers that will bring back a particular memory, like PTSDs. Okay, so some people got washed away in the tsunami. The moment they see the sea or water, immediately the memory will come back into their consciousness, and they start becoming so panicked. They start reliving it. So that thing you need to understand. And what is the nature of the family and emotional support? What is their personality style? Do they have any drug or alcohol history? And now you also have to rule out whether they have any behavior addictions, like PUBG or internet, spending excessive time. That is what we call the problematic internet usage. You are spending a lot of time, more than 1 hour, unless you are working on a project on internet, unless you are a software engineer, or unless you are working in Google, unless you are working in some ad agency, or what you call social networking site engineer, or you are a content developer on websites. You are, if you are spending more than 1 hour on internet, that means you are addicted every day. If you do it regularly, that means you are in the problematic internet usage. Okay, that you have to rule out. Is the client spending more time on the pornography? Whether he has any masturbatory history followed by the pornography, that also you have to assess, because now these psychopathological cases with pornography or extramarital relationships and all are now becoming very much prevalence. The prevalence is excess in the current scenario. So what is the understanding and explanation of their current condition? Do they have insight or not? Insight refers to not about awareness about their life. Insight refers to awareness about their psychological problem or psychiatric condition, whether they believe and they accept that they have some psychological problem or not. Okay, so there are 6 levels of insight. So grade 1, grade 2, grade 3, grade 4, grade 5, and grade 6. So that you have to assess. So grade 1, I know that I have a problem, but I deny it totally. That is called grade 1 insight. Grade 2 insight, I know that I have a problem. At the same time, I will not accept it. Okay, I'm not denying. Okay, but wholeheartedly, I'm not accepting it. Grade 3, I know that I have a problem, but I'm telling you are the cause for my problem. As I'm putting it on the family, or I'm blaming the environment for the reason, because of my school, because of my environment, because of my parents, because of my wife, because of my what you call sisters, or because of somebody. I'm blaming somebody. So that is called grade 3 insight. Grade 4 insight, that you know that you have problem, but you don't know what the problem is, how to resolve, okay, how to come out of the problem. You don't know what the problem is, but you know that you have a problem. That is grade 4. A grade 5 is an intellectual insight. Intellectual insight means you know that you have a problem, you know what sort of problem also that you have, but you do not have the resources how to resolve and come out of it. Okay, right. You are helpless at that time. That is grade 5 insight. Grade 6 insight is what we call true emotional insight. True emotional insight in sense that you are so happy that you know problems are the part of your life. You are like effective sailor, like tides and storms do come, and you are effective sailor. You are surfing. You are surfing on the ever-changing sea. So grade 6 is something that you know that you accept that problems are part of life, and you have the greater resiliency and resources to resolve the day-to-day problems and live with a lot of what you call peace, contentment, satisfaction despite adversities. Okay, so the main goal of psychoeducation to facilitate understanding about the disorder and management. Okay, mental disorder is a illness, not a sign of weakness. Recovery is the rule, not the exception. Okay, so treatment is effective, and there are many treatment options available. Goal of treatment is to get well and minimize relapse. When we come about this treatment plan, there are totally 4 phases. One is remission, relapse, recovery, and recurrence. Okay, many people after taking treatment, they are improving. That is what we call remission. Okay, then they have to go into the recovery phase. Before they go into recovery phase, if some other problems come, or suddenly some problem comes, that will hamper the functioning of the individual, or there is sudden stressful situations. Okay, like somebody death, or somebody sudden loss of job or property, there is some problem suddenly, then that can put a person into relapse. Especially alcoholics, they go for the treatment, they are in the treatment for 3 months or 6 months, they come out of the what you call the rehabilitation center, and they are fine, they're doing well. Suddenly what happens, there is a loss of job, or somebody in the family will disown that person. Then what happens, they go into relapse, means they get back to the same alcohol abuse again. So relapse is there, recovery is there, means you totally recover and you maintain that well-beingness. Okay, then you have recurrence, means the problem can come. A person who has a depression may also get a depression after 3 years or 4 years or 5 years. Okay, that is recurrent. Okay, recurrence is there. So these are the phases of the treatment. Okay, now recognizing and acting early are warning signs. So when you find that problem has started, in the initial stages only you should treat. Okay, if you treat, then the what you call the recovery rate or the improvement rate is high. If it is slowly getting, years are passing or days are passing, what happened, the prognosis become poor. Okay, it is just like when you meet with an accident, you broke your hand or leg. Immediately, if it is operated, the orthopedician will put 2 rods and he will attach the bones, so the bones will heal by themselves. That is actually what happens in the procedure. But if it is delayed by 10 days, what happens? The gumming material is exhausted, so it becomes difficult to join. After 1 year, it becomes completely exhausted. There is no gumming material in the bones, so you cannot attach it and you cannot heal properly. So that's how with the psychotherapy or medication or any form of psychological treatment. Okay, we'll not go to that much. You all know cognitive therapy. Okay, main purpose is to improve the behavior functioning. Okay, preventing relapse. Now, the focus of the clinical psychology or counseling psychology, because they are overlapping what you call fields. So lifespan approach to health and healthcare for children, teens, adults, seniors in a racially and ethnically diverse community. Behavior interventions like changes in behavior and lifestyle can improve health, prevent illness, reduce symptoms of illness. Behavior changes also help people to feel better physically and emotionally, improve their health status, increase their self-care skills, improve their ability to live with chronic illness, and also the interventions, that is behavior interventions, can improve effectiveness of medical interventions, help reduce overutilization of the healthcare systems, reduce the overall costs of care. Examples of training in behavioral interventions include coping skills training, relaxation training, self-monitoring personal health, stress management, time management, pain management, problem solving, communication skills, priority setting. Examples of social support include group education, caretaker support and training, health counseling, community-based sports events. Examples of behavioral interventions like biofeedback, cognitive behavior therapy, neurofeedback, meditation, guided imagery, mindfulness, clinical self-hypnosis, relaxation training, muscle relaxation, yoga, tai chi, transcendental meditation, self-regulation skills, okay, to put control on the health under one's own personal locus of control. So you are also trying to improve the personal locus of control, means you believe that you are responsible, whatever you are doing, whatever is happening with you, you are responsible for your emotions, your thoughts, your belief systems, your expectations, your values, your decisions. You are responsible for whatever is happening with you because these are under your control. What is the outcome of goals of behavior interventions? Prevent disease onset, lower blood pressure, lower serum cholesterol, reduce body fat, reverse atherosclerosis, that is blocks in your what you call arteries, decrease pain, reduce surgical complication, decrease complications of pregnancy, enhance immune response, increase compliance with the treatment, medication plans, increase relaxation, increase functional capacity, improve sleep, improve productivity of work and school, improve strength, endurance and mobility, improve quality of life. Age-related focus, children's health, adolescent health, women health, men's health, aging, brain, neuroplasticity. Means we have the greater adaptation of developing the neuro connections. Means you every year you learn something new, you learn music, you learn new language, German, French, or Malayalam, Telugu, Tamil, whatever language that you learn every year, or something new, any new skill that you learn, it will improve the neuro connections. Means you form new associations with the existing information. That is what we call the neuroplasticity. Weight management focus like obesity or exercise, diet, nutrition, cognitive approach to approaching weight, body image, eating disorders. Sleep related focus. See, this is our new domain like insomnia, sleep hygiene, sleep deprivation, sleep apnea, snoring, narcolepsy, restless legs syndrome, circadian rhythm disorder, somnambulism or sleepwalking, connection with metabolism, exercise, productivity. Emotion related focus, you already dealing with depression, anxiety. Some people are also dealing with OCD, PTSD, panic disorder. Musculoskeletal related focus like arthritis, chronic pain, disease related pain, low back pain, myofascial pain, fibromyalgia, accident related pain, multiple sclerosis, lupus, Parkinson's disease, ALS. Rehabilitation focus, you can work in this area also, developmental disabilities, accident related, neurological condition related, anti-aging. Pulmonary related focus, asthma, allergies, cystic fibrosis, pulmonary disease. Allergy related focus, seasonal allergies, food allergies, environmental allergies. Cardiovascular focus like type A, type B personality style. Chronic hostility was a lowered hostility, heart disease, hypertension, stroke, these are interrelated. Gastrointestinal focus, you have diabetes, incontinence, irritable bowel syndrome, ulcers. Renal disease related focus, dialysis, kidney transplant process. Neurological related focus, you have neurodevelopmental conditions like ADHD, autism, SLD, that is specific learning disability, and conduct disorders, developmental delays, headaches, epilepsy, TBI, traumatic brain injury, tics, brain plasticity. Cancer related focus like early identification of symptoms, coping with diagnosis, coping with treatments, coping with physical health during treatment process. Like you can also work in this area, most of the clinical psychologists are working. So information on HIV AIDS, like information STDs. Addiction related focus, you can work on substance abuse, alcohol, illegal drugs, prescription drugs, tobacco, nicotine, that is caffeine, there is non-addictive substances, other compulsive addictions like gambling, sex, computer, connectedness with other focus like improving social relationship. Now, relationship area is a key area where counseling psychologists can work on. Isolation, loneliness, avoidance of contact with others, sense of community. Spirituality focus like internal versus external locus of control, spiritual practices which increases healing and good health, maintaining a positive outlook on life which encourages physical healing and good health. Death and dying focus. We can work in this area, what we call the science of thanatology. Okay, Eros, Thanatos, these are postulated by the Sigmund Freud. Sigmund Freud in his book has given the life instinct and the death instinct. So now you are helping the individuals to die with dignity. People who have catastrophic illnesses, especially very malignant conditions like cancer and other tumors and all that, you can also help them. You can give counseling to them. You can make them come to the terms. Like you have a DAPDA model, that is what we call denial, anger, bargaining, again depression. Last comes the acceptance of the condition. Okay, so maintaining one's composure facing the end of life. Conclusion: at a purely conceptual level, a solid case can be made for investing in mental health, whether on the grounds of enhancing individual and population health and well-being, reducing social inequalities, protecting human rights, or improving economic efficiency. In short, mental health is far greater than wealth. I think with this, I come to a closure of this session. Thank you. Any doubts, you can ask.
Right, sir. Now it's open for question here. Please ask your questions. So do you have any questions on this today's topic? Please ask a question. Haraprasad sir, am I audible?
Yeah, you're audible. Ramohan garu ready avutunnaru.
Okay, okay.
Sir,
Speaker on chesaru ayana.
Usha garu, Haraprasad garu,
Sir.
today's session is too technical and too professional.
అవునండి.
అంటే ఇక్కడ పార్టిసిపెంట్ సైకాలజిస్టులు ఎవరన్నా అడిగితే క్వశ్చన్ బాగుంటుంది. క్వశ్చన్ అడగడానికి కూడా ఐ మే నాట్ బి ఏ సూటబుల్ క్యాండిడేట్, బట్ ఎనీవే.
అది మీరు స్పీకర్ ఆన్ చేయగానే మీరు అడుగుతున్నారేమో అనుకున్నాను.
నేను అడుగుతాను. బట్ నేను ఐ జస్ట్ వాంటెడ్ టు.
అంటే యాక్చువల్లీ సార్, ఓకే, టుడేస్ టాపిక్ ఈస్ టోటల్లీ related to profession who are practicing and who are into that profession. But you can ask the question which is related to your motivational speeches or anything.
Agree.
Sorry, is all rounder. As everyone.
Agree. ఆ కోణంతోనే, ఆ దృష్టితోనే ముందుకు వచ్చాను. వీరికి శ్రీకాంత్ గారికి తెలుగు వచ్చా?
వచ్చండి.
వారికి అర్థమవుతుంది తెలుగు? Okay, sir. No, I can speak in English, Hindi, Telugu, Sanskrit, and even Tamil also to little extent. That is a different thing. But my main question here is, sir, you are dealing with all the people, branded patients, mental disorders of varying grades, and how to treat them, how to bring them back. This is wonderful. My concern is that among the so-called normals in our day-to-day life, we see many people who are a sort of difficult, I say HCTN, hard HNTC, hard nuts to crack. తెలుగులో చెప్పాలంటే కుర్రుకుడు బడని మింగుడు బడని మనుషుల్ని మనం చూస్తుంటాము. They have some problem definitely, but not to the extent of going to a mental health professional and taking treatment, but they are definitely hurdled or a setback or a drag to their own community, family members or colleagues. Can you say something? I mean, they are on the margin. They are the margin, but you are using some words like they are resilient to claim their stake, be resilient with that, but always cause problem to others. These people from the mainstream I am talking about, I think you got the point. Your take on this, sir.
Very interesting quote, sir. God will help those who help themselves. So even God cannot help them. Those people who are almost found in every section of the society or community. Okay.
Yes, sir.
So when the appropriate time comes before they die, at least 1 minute God will change them, I suppose. మనిషి చనిపోయే ముందు ఈవెన్ మహాభారతంలో దుర్యోధనుడైనా చనిపోయేటప్పుడు 1 నిమిషం మంచి వ్యక్తిగా మారి తర్వాత ఆయన ప్రాణాలను కోల్పోయాడు. దేవుడు ఆ రియలైజేషన్ ఇస్తాడని మనం ఆశిద్దాం. If you believe in God.
Okay, good.
Again, the external locus of control comes into the picture.
Good. Right, sir. Thank you.
Thank you.
Okay. Srikanth says, good session, sir. Thank you. Balaji, sir, happy evening. Do you have any questions to ask? Please, put forth so that, we all will be invited. We are all sharing knowledge together.
Yeah, honestly speaking, I joined a bit late. So I missed most of the session, I suppose. So because of some internet problem, I couldn't join myself on time. So that's the reason koncham late ayindi. But in any case, sir, yeah, two things which we normally practice, at least I'm not a practicing psychologist as such, but I work towards suicide prevention for quite some time, sir. So that's my, what you call, parichayam to you, Srikanth Garu. Yeah, am I audible?
Yeah,
Absolutely.
Yeah.
Okay. Now there is a jinx with your program as far as I am concerned, sir. Intakundu kuda oka association lo meer itlage program icharu, but I was not able to join that course also. That time also. Okay. So I'm mostly into, I have nothing to comment on what you're talking about. But one thing is sure, as far as the parallel support, what you said needs to be given to terminally ill patients or the psychologically down patient, make them accept certain items like, befriending them or trying to tell them, come in terms with what it is. Accepting the reality part of it is everybody's responsibility. And yes, we have to do that. That's what is my total concern. I'm into, so where do you practice, sir?
I have my own clinic at Hapsiguda.
At Hapsiguda?
Yeah, Hapsiguda.
Okay, very close to my place, sir.
A lot of polyclinics and corporate hospitals simultaneously. Because of COVID, currently I'm restricting my practice to Hapsiguda.
Yeah. Excellent, sir. So that's an excellent thing. So the one takeaway that I could get from the small this thing is that yes, somewhere down the line, the pattern 1 and 2 that you told about the type of people, grade 1, grade 2, grade 3, grade 4, grade 6, right? So in that grade 1 and 2 are the ones which needs to be educated the most. Probably they will have to be told that yes, going to psychologist is not an indication of going to a mental hospital, but it's a sort of a checkup where we normally go and try and do something for our own belief and best thing. And that's what I normally tell to many of the people. So that was a very interesting session. And the other takeaway that I got from this is, yes, terminally ill patients, like in all the palliative cares, etc., Sparsh cares, etc., and all, I normally do this, M&J Cancer Hospitals and other things. So I could gauge that difference in people when we go and talk to them, when we go and address them, when we at least acknowledge them what it is. Everybody will advise them, everybody will take them to a different path, but nobody will allow them to open up on their own. And once we do that as a normal person, as an ordinary person, as a responsible person, many problems can get sorted out and maybe the end can be very peaceful then normally with all confusions and hairana padakunda koncham normal ga undochu annadi na abhiprayam sir. That's something good. And I don't know if I can ask this question or not, but then is it possible for you to share your PPT, because I couldn't see right from the beginning.
That is my brainchild, sir.
Yes, sir. Excuse me,
That's
sir.
what.
Sir, before Shrikant sir, accept that we already, going live on Path. My humble request with all the participants, all the psychologists and all the counselors, please do watch us on Path. There is a YouTube channel you can see, because
Okay.
see, I
Excellent.
respect everybody. ఎందుకంటే ప్రతి ఒక్కళ్ళు వాళ్ళ టీచింగ్ ఐడియాలజీతో వాళ్ళ స్లైడ్స్ ప్రిపేర్ చేసుకుంటారు కాబట్టి, and we never, I mean, every copyrights వాళ్ళవే. So my humble request for all people is like just learning from each other. It's not like
I respect that. So I respect that, and I go by that. There is no confusion. Andukane I had a hesitation in asking, since I had some since I was late, so I thought I missed out something.
Okay.
In any
Sir,
case, sir,
I
it was
also-
quite
I
interesting
want-
whatever little I heard about. So thank you so much, sir.
Yeah, thank you so much.
sir,
And,
after this session
one
I'll share the
request.
link, sir, so that you can watch.
One request for the Path Association organizers, that before you record the session, kindly take the permission of the speaker also. Okay, all will not be willing to share their content or this thing. Okay.
Yeah, sir, we are doing that, sir. Sorry, actually we are
I
doing
was
that.
not given. I have not given any permission so far to record the session, but okay, this time okay, I excuse. But usually I do not appreciate people without my consent or my knowledge regarding the session. Okay.
Right, sir. Right, sir.
Sorry for
We'll
that,
consider this point definitely, sir.
Without your permission, will not upload.
Okay, sir. Thank you so much, sir. Thanks for your time, sir.
Any more questions on this regard? Please.
Hi, ma'am. Yeah,
Hi,
myself Anusha, ma'am. Sir, I have one question. Wonderful session, sir. Which therapy is best for personality disorders, borderline personality and narcissistic?
You are practicing psychologist, Anusha ji?
Yes, sir.
Okay. What is your qualification?
MSc psychologist, sir.
MSc psychology. Okay.
Yes.
Have you worked under any psychiatrist or a clinical psychologist at least not less than 2 years?
Yeah, yes, sir.
Where have you been working so far?
With Guntur Government Hospital, sir, and Vijayawada, sir, in-laws Shantivan.
Okay. Guntur Hospital Psychiatry Unit. Did you work with any of the psychiatrists?
Yes, sir.
Okay. Because my friend is a professor there. He is the head of the department, Professor Dr. Nalluri Muralikrishna. Okay. So he's
My
colleague,
HOD, sir. HOD, sir.
Your HOD, sir. Okay. Fine.
Yeah.
So you just ask him. Okay. So to work on the borderline personality disorder, it's a clinical condition. Okay. You will have all symptoms of schizophrenia. You will have symptoms of anxiety, depression, psychosis, lots of it. It's a complex personality disorder. Okay.
Yes, sir.
And unless you have clinical training, unless you have a supervised training for at least 2 years in the mental health setup, you should not touch that condition. Okay. You are not trained in that modality, so you should not attempt first things. Okay. And coming to the therapies, as you asked for information, usually we do dialectic behavior therapy in borderline personality disorders, because it is dialectic, means the two polarities. Okay, one thing that I want to kill myself, other thing that I want to live. So you are stuck. Okay, so that two polarities are addressed. Okay, so it's a complex condition. You need to assess the mental health status. You need to also assess the current functioning. Then only you can do therapy. Okay. So it's better that you should, if you are treating any borderline personality disorder, please do work under some supervision. Otherwise, if there is some legality issues, usually the borderline personality people with borderline personality BPD patients will create some problems, like they can do self-harm, or they can put on the client, can put a blame on the therapist who is treating, okay, or on the consultant, okay, or they go to a legal like police station, or they can file a complaint on the family members. Sometimes they can do anything, okay. So this is what it is, because they are having problem in the what do you call integration. Basically, they have different parts in their personality. They are not integrated. So they are having poor ego strength. So this is a complex condition. That's the reason you should not work on this condition unless you are under a supervision of a psychiatrist who is a main consultant. You can definitely, you can do some counseling, or you can do some therapy if you are trained, but under supervision of a licensed professional only, you should attempt to treat the borderline personality. Okay.
Okay, sir.
That
Thank you,
I have
sir.
answered your query.
Thank you, sir. Thank you so much.
Right, sir. We have done almost all. We have done with all the questions and the answers, I believe.
Yeah, madam.
Anusha, I believe sir answered your question, right?
Yes, ma'am. Thank you, ma'am.
Yeah. Okay. So what proceed, sir?
Yeah, madam.
5 more minutes. First. Alprasad sir, am I audible? Sir, am I audible?
You're audible. You're audible.
Okay. Still, do you have any questions? No, right?
Yeah, it's okay.
Okay. So this on this positive note, like whatever instructions, whatever guidance, whatever insights, whatever inputs given by sir, definitely we'll follow. And we all happy to share such a wonderful awareness program. As said, Path Association has come up with a wonderful thought to create awareness first of all, and educate all of us. Manam kuda psychologists laga, counselors laga, therapists laga, we have to learn from each other అని ఒక మెయిన్ ఉద్దేశంగా. At the same time, because there are many teachers, we could see like teachers ఉన్నారు ఇక్కడ, and many people who just wanted to have that knowledge, they have joined Path. And on this wonderful note, again I just wanted to thank Shrikant sir, who accepted, who agreed to deliver a talk on Path. Once again, I take this opportunity to thank you, sir. Thank you once again. And happy participants. Really very good to see you all taking part in this Path. And do share this knowledge with other people, because so that they can create this awareness రావడము అనేది మెయిన్ ఉద్దేశం. So that's what I request all the participants, like see 4 more days left with us. I want everybody, మేము ఏదైతే లింక్ షేర్ చేస్తున్నామో just share in your group, so that they all are getting that education, awareness, and they share the joy of caring with each other. That's it. Thank you, sir, once again. Thank you all the participants. Good night and take care.
Thank you, Srikanth sir, and thank you everybody.
Thank you.